Welcome to the Hospital Medicine Unplugged podcast.
It is fantastic to have you with us today.
It really is. And whether you are, prepping for your next set of clinical rounds or you're trying to wrap your head around complex, systemic, autoimmune-like responses.
Or maybe you are just insanely curious about how doctors solve some of the most intricate medical mysteries out there.
Exactly. Whatever your reason, this deep dive is going to be your ultimate roadmap.
Because today, we are looking at a disease that essentially acts as the ultimate clinical chameleon.
Sarcoidosis?
Sarcoidosis. And specifically, we are looking at this through the lens of its clinical foundations.
Right. We are going to explore how it is diagnosed when it mimics a dozen other pathologies.
How it is managed across multiple organ systems.
And the critical, often counterintuitive nuances that dictate when we actually intervene.
To do that, we have an incredible stack of medical literature in front of us.
We really do. It is a gold mine. We are pulling insights directly from the NEJM,
the JAMA,
the American Thoracic Society Guidelines, or ATS,
the American Heart Association,
and the American Family Physician Journal.
Our mission today is to cut through the dense medical jargon.
We want to really understand how this disease operates at a cellular and systemic level.
Starting with the very foundation of how a clinician even begins to confirm a patient has sarcoidosis.
Right. And that brings us to the diagnostic triad.
It is the absolute cornerstone here.
Because diagnosing sarcoidosis isn't like diagnosing a straightforward bacterial infection.
No, not at all. You can't just culture an organism, identify a specific strain of Streptococcus or E. coli, and have your indisputable answer.
It is notoriously tricky.
It is, mainly because the disease itself doesn't have a single definitive biomarker.
So the diagnosis relies on three essential components.
Right. First, you need a compatible clinical presentation.
The patient's signs and symptoms have to actually fit the established profile.
Exactly. Second, in most cases, you need histologic evidence of non-caseating granulomas.
And third,
you have to rigorously exclude alternative causes of granulomatous disease.
Let's hover on that histologic evidence for a moment. Because finding a granuloma under a microscope isn't the finish line.
Not even close.
A granuloma is, it's essentially a cellular clump.
Right. It is a very organized, tight collection of inflammatory cells.
Specifically macrophages and T lymphocytes.
And the immune system forms this clump to wall off something it perceives as a threat.
Something it cannot easily digest or eliminate.
The immune system essentially builds a cellular prison.
I love that analogy. A cellular prison.
Right, because when macrophages encounter an indigestible antigen, they actually undergo a transformation.
They fuse together.
Exactly. They fuse to form these multinucleated giant cells.
And then they're surrounded by a collar of lymphocytes.
This is the body's primary way of containing a microscopic threat.
But there's a major catch here.
The immune system has a limited repertoire of responses.
It forms these exact same non-caseating granulomas in response to a whole host of other triggers.
Which means the presence of a granuloma is really just a biological alarm bell.
It tells you the immune system is actively walling something off.
But it doesn't tell you what triggered the alarm in the first place.
You could be looking at a reaction to certain fungal infections.
Like histoplasmosis or coccidioidomycosis.
You could be looking at mycobacterial infections.
Most notably, tuberculosis.
You could even be looking at occupational exposures.
Right. Berylliosis is a classic example.
That occurs in aerospace and electronics workers exposed to beryllium.
And it creates a histologic picture that is virtually indistinguishable from sarcoidosis.
Which is why sarcoidosis is firmly classified as a diagnosis of exclusion.
You cannot simply biopsy a lymph node, see a non-caseating granuloma, and confidently stamp sarcoidosis on the patient's chart.
You have to prove that it isn't tuberculosis.
You have to prove it isn't histoplasmosis.
You have to take a detailed occupational history.
Exactly. You must rule out beryllium or silica exposure.
Only when you have meticulously cleared the field of those other suspects can you establish the diagnosis of sarcoidosis.
But getting that tissue sample in the first place is a major hurdle.
Especially for hospitalized patients who need a definitive answer quickly.
The sources point to a very specific preferred method for obtaining that histologic confirmation.
And that is EBUS-guided.
Endobronchial ultrasound-guided transbronchial needle aspiration.
Historically, getting a tissue sample from those deep chest lymph nodes was a lot harder.
The mediastinal and hilar nodes where sarcoidosis frequently manifests.
Right. That used to require a mediastinoscopy.
Which is a surgical procedure. It requires general anesthesia.
An incision is made at the base of the neck.
A scope is passed down along the trachea, and tissue is mechanically excised.
It carries inherent surgical risks.
Bleeding, infection, and damage to the recurrent laryngeal nerve.
Putting a patient through a surgical procedure just to get a tissue sample is a lot.
Especially when the pulmonary function might already be severely compromised.
It is a significant undertaking. But EBS-TBNA completely revolutionized this approach.
It did, by combining endoscopy with sonography.
So a pulmonologist passes a flexible bronchoscope down the patient's airway.
And at the very tip of this scope is a miniature ultrasound probe.
This allows the physician to look through the opaque wall of the airway.
And actually visualize the swollen lymph node sitting on the other side.
They can see the blood vessels.
They can measure the node.
And then they can guide a fine needle directly through the airway wall.
Perfectly into the center of the node to aspirate cells.
It is minimally invasive.
It can often be done under conscious sedation rather than general anesthesia.
And it has a remarkably high diagnostic yield.
For a hospitalized patient, it perfectly balances safety with the critical need for an accurate tissue diagnosis.
But the medical literature always has exceptions.
Always.
There are highly specific clinical scenarios where the presentation is so distinct that a biopsy isn't actually required.
Clinicians look for what we call pathognomonic presentations.
Meaning, a clinical syndrome is so uniquely specific to a single disease that merely observing it is essentially diagnostic.
The two classic examples highlighted in the ATS guidelines are lupus pernio and Löfgren syndrome.
Let's start with Löfgren syndrome, because it is a very specific four-part clinical cocktail.
It was named after Sven Löfgren, a Swedish physician who recognized this pattern back in the 1940s.
The first component of this quartet is bilateral hilar lymphadenopathy,
You will see swollen lymph nodes on both sides of the chest.
usually identified on a standard chest radiograph.
That is the radiographic hallmark.
The second component is erythema nodosum.
These are intensely painful, red, inflammatory nodules.
They typically erupt on the anterior shins.
It is an inflammation of the fat cells under the skin, a paniculitis,
The third component is arthritis,
or at least a profound periarticular inflammation.
most frequently affecting the ankles.
And the fourth component is a fever,
When a patient presents with that specific quartet,
the bilateral hilar adenopathy,
the erythema nodosum,
the ankle arthritis.
and the fever,
The ATS guidelines assert that the probability of sarcoidosis is so overwhelmingly high that you can bypass the EBS-TBNA entirely,
you spare the patient the invasive procedure.
because the clinical picture itself is doing all the diagnostic heavy lifting.
The exact same logic applies to lupus pernio.
Despite the name, it has absolutely nothing to do with systemic lupus erythematosus.
It presents as violaceous indurated skin lesions.
Essentially firm, purplish, chronic plaques.
They typically develop on the nose, cheeks, lips, or ears.
And it is incredibly characteristic of chronic fibrotic sarcoidosis.
It is a disfiguring dermatologic manifestation.
It strongly correlates with aggressive disease in the upper respiratory tract and the lungs.
Recognizing lupus pernio allows a clinician to secure the diagnosis clinically,
And immediately pivot to managing the disease.
rather than spending weeks chasing down a biopsy.
But securing the diagnosis, whether through EBS-TBNA or by recognizing a pathognomonic syndrome, is really merely the opening move.
Right, because once sarcoidosis is confirmed, you cannot simply focus on the lungs.
You absolutely cannot assume the rest of the body is fine.
Which leads us directly into the mandatory systematic screening outlined in the literature.
The American Thoracic Society guidelines are totally uncompromising on this point.
Systematic screening for organ involvement is absolutely mandatory once sarcoidosis is suspected or confirmed.
Because sarcoidosis is a multisystem disease.
It can, and frequently does, deposit non-caseating granulomas in virtually any organ in the human body.
Think of it like auditing a compromised electrical grid.
That is a great way to visualize it.
If you find a blown transformer in one neighborhood, say the lungs,
You cannot just fix that one transformer and assume the rest of the city has power.
that single blown transformer suggests a systemic surge.
You have to methodically check the substations in every municipal zone,
Because the grid is interconnected.
and damage in one area might be quietly cascading into another.
That captures the clinical mindset perfectly.
The terrifying aspect of sarcoidosis is that it can inflict irreversible organ damage entirely silently,
A patient might have granulomas slowly destroying their renal parenchyma
or infiltrating their myocardium.
without feeling a single symptom until a catastrophic failure occurs.
So you are not waiting for symptoms to appear.
You are actively hunting for silent disease.
Let's walk you through these baseline evaluations, starting with the pulmonary system.
Even if a patient doesn't report a cough or shortness of breath, a pulmonary evaluation is non-negotiable.
Baseline chest imaging is standard
Frequently utilizing a high-resolution CT scan.
because a standard chest X-ray can show you enlarged lymph nodes.
But an HRCT provides a granular view of the lung parenchyma itself.
It allows the radiologist to look for subtle ground glass opacities
Micronodules along the bronchovascular bundles.
or early signs of architectural distortion and fibrosis.
But seeing the structural changes is really only half the equation.
You need to know how those structural changes are impacting actual lung function,
That requires pulmonary function tests, or PFTs,
specifically including DLCO.
the diffusing capacity of the lungs for carbon monoxide.
The PFTs measure the mechanical volumes,
How much air the patient can inhale and exhale.
but the DLCO measures the efficiency of the alveolar capillary membrane,
It tells you how well gas is actually crossing from the air spaces into the bloodstream.
because granulomas in the lung interstitium thicken that membrane.
Impairing gas exchange long before the lung mechanics themselves are severely compromised.
A dropping DLCO is often the earliest functional indicator that pulmonary sarcoidosis is progressing.
Moving from the lungs, the guidelines mandate an evaluation of the eyes.
An ophthalmologic evaluation, specifically utilizing a slit lamp examination, is required.
A standard visual acuity test with a Snellen chart on the wall is completely insufficient here.
Reading letters on a wall only tells you if the optics of the cornea and lens are focusing light correctly onto the retina.
It tells you nothing about the inflammatory state of the uveal tract.
Sarcoidosis has a profound predilection for the uvea.
The pigmented middle layer of the eye that includes the iris, the ciliary body, and the choroid,
The immune system forms those non-caseating granulomas right there in the tissue.
causing uveitis.
And anterior uveitis can be entirely asymptomatic in its early stages.
A patient might experience slight photophobia
Just as sensitivity to light.
or mild blurred vision that they just brush off as fatigue.
But left unchecked, the chronic inflammation can lead to posterior synechia,
Where the iris actually adheres to the lens.
secondary glaucoma,
Accelerated cataracts.
and ultimately permanent vision loss.
The ophthalmologist uses the slit lamp to project a high-intensity beam of light into the eye
This allows them to look microscopically into the anterior chamber.
and actually visualize individual white blood cells floating in the aqueous humor.
It is the only way to detect early, silent ocular sarcoidosis.
After the imaging and the eye exam, we get into the laboratory work.
Checking the metabolic and renal systems.
The guidelines recommend a complete blood count to look for cytopenias,
An alkaline phosphatase level to screen for hepatic granulomas.
and a serum creatinine to assess baseline kidney function.
But the most fascinating biochemical aspect of sarcoidosis lies in the calcium and vitamin D axis.
The guidelines specify checking serum calcium.
And if you are assessing vitamin D, you are required to check both 25-OH vitamin D and 1025-OH vitamin D levels.
The pathophysiology behind this recommendation is one of the most remarkable examples of disease biology mimicking normal endocrinology.
In a healthy physiologic state, vitamin D from the skin or diet is converted in the liver to 25-OH vitamin D,
That is the storage form.
then strictly regulated by the parathyroid hormone and the body's need for calcium.
The kidneys use an enzyme called 1-alpha hydroxylase,
To convert that storage form into 1025-OH vitamin D.
which is a highly active form,
The active 1025-OH vitamin D travels to the intestines.
and drastically increases the absorption of calcium from the diet.
It's a tightly controlled feedback loop.
If calcium levels rise, parathyroid hormone drops,
The kidneys stop producing the active vitamin D.
and calcium absorption halts.
But in sarcoidosis, the macrophages that make up the granulomas essentially go rogue.
They express their own 1-alpha hydroxylase enzyme.
They independently convert the 25-OH storage form into the active 1025-OH form.
Completely bypassing the renal regulatory system.
The granulomas do not listen to parathyroid hormone.
They do not care if the serum calcium is already high.
They just continuously pump out active vitamin D,
This floods the systemic circulation with the active hormone.
which continuously signals the intestines to absorb massive amounts of calcium.
The patient develops hypercalcemia,
And importantly, hypercalciuria,
an excess of calcium spilling into the urine.
which can crystallize into kidney stones
So is nephrocalcinosis.
and eventually lead to irreversible renal failure.
If a clinician only checks the standard 25-OH vitamin D level,
which is the typical assay ordered during a routine physical to check for a vitamin D deficiency.
it might look entirely normal.
Or, ironically, it might even be low.
Because the granulomas are rapidly consuming it to make the active form.
The clinician might mistakenly prescribe a vitamin D supplement.
But the 1025 OH level could simultaneously be dangerously high.
You have to check both to see the full aberrant biochemical picture.
That perfectly illustrates why the diagnostic and screening approach must be so rigorous and mechanism-driven.
But among all the systems we are auditing in this multi-system disease,
there is one that demands the absolute highest level of vigilance.
the stakes here are quite literally sudden death.
We have to examine the silent threat of cardiac sarcoidosis.
When we look at the mortality data for sarcoidosis, cardiac involvement is the second leading cause of death.
Surpassed only by end-stage pulmonary fibrosis.
The deception of cardiac sarcoidosis is profound.
A patient can have a massive burden of pulmonary granulomas.
Requires supplemental oxygen.
And yet have a perfectly healthy heart.
Conversely, a patient might have a normal chest X-ray
Breathe effortlessly.
and have granulomas quietly infiltrating their myocardium.
Setting the stage for a fatal arrhythmia.
Because of that unpredictable disconnect between pulmonary and cardiac involvement, the American Heart Association guidelines are definitive.
A baseline 12-lead ECG is strongly recommended for all patients diagnosed with sarcoidosis.
There are no clinical exceptions to this rule.
A standard physical examination with a stethoscope will not reliably detect an early conduction block.
The baseline 12-lead ECG is the absolute minimum screening imperative.
You are looking for subtle electrical disruptions,
The granulomas physically interpose themselves into the myocardial tissue,
frequently targeting the basal interventricular septum,
where the critical electrical conduction pathways reside.
the bundle branches.
So the screening trips the alarm. The literature outlines very specific red flags that demand an immediate escalation to advanced cardiac imaging.
We are looking at clinical symptoms like syncope,
Unexplained fainting spells that suggest transient drops in cardiac output.
or profound sustained palpitations,
Or if that baseline ECG shows abnormalities.
particularly a high-degree atrioventricular block or bundle branch block.
If a patient with known sarcoidosis presents with syncope.
You must assume it is a ventricular arrhythmia or a transient complete heart block until proven otherwise.
You do not wait for a second episode.
You must visualize the myocardial tissue itself.
And an echocardiogram is often insufficiently sensitive to detect patchy, early granulomatous infiltration.
The modalities of absolute choice here are a cardiac MRI or an FDG PT-CT scan.
A cardiac MRI relies on a specific technique called late gadolinium enhancement, or LGE,
Gadolinium contrast is injected,
and it washes out of healthy heart muscle quickly.
but it lingers in areas where the tissue is expanded by inflammation or replaced by fibrotic scar tissue.
The LGE highlights the exact anatomical footprint of the damage.
It shows you the scarring left behind by the granulomas.
An FDG PET-CT, on the other hand, utilizes a radioactive glucose analog.
Active inflammatory cells, like the macrophages in a forming granuloma, are highly metabolically active.
And consume large amounts of glucose.
The PET scan lights up these areas of active burning inflammation.
Often clinicians will use both.
The MRI to map the scarring and the PE scan to identify the active inflammation.
Once cardiac involvement is confirmed, the management strategy requires a highly coordinated dual approach.
You are fighting a war on two fronts.
You have to stop the active inflammation from destroying more tissue.
But you also have to protect the patient from the structural and electrical damage that has already occurred.
The first arm is profound immunosuppression.
This almost universally begins with high-dose corticosteroids.
The objective is to rapidly suppress the immune response
Halt the metabolic activity of the granulomas.
and preserve whatever healthy myocardium remains.
In some instances, aggressively initiating steroids early enough can actually reverse an atrioventricular block.
By shrinking the granuloma before it turns into a permanent scar.
But steroids cannot reverse fibrosis.
If a granuloma has already caused necrosis and left behind a dense collagen scar in the conduction pathway,
The electrical signal will remain blocked regardless of how much prednisone you administer.
that necessitates the second arm of treatment.
Device therapy.
This involves the placement of implantable cardioverter defibrillators, or ICDs, and permanent pacemakers,
If the patient has a high burden of left ventricular scarring,
and is at high risk for a fatal ventricular tachyarrhythmia.
the ICD is implanted to monitor the rhythm and deliver a life-saving shock if the heart goes into a lethal rhythm.
If the primary issue is a conduction block, The pacemaker is required to maintain an adequate heart rate.
In highly specialized centers, electrophysiologists might even need to perform catheter ablation
They map the electrical circuits of the heart.
and essentially burn away the specific microscopic pathways that are facilitating the short circuits.
Caused by the granulomatous scarring.
The urgency of establishing this dual therapy is underscored by a critical data point from the literature.
Up to 75% of patients with cardiac sarcoidosis will experience a relapse of their inflammation when their initial course of corticosteroids is tapered.
75%. That is a staggering failure rate for monotherapy.
It fundamentally alters the therapeutic algorithm.
It dictates that for the vast majority of patients with cardiac sarcoidosis, corticosteroids alone are merely a temporary bridge.
The moment you attempt to lower the steroid dose to mitigate the inevitable systemic side effects,
The myocardial inflammation flares right back up.
this sets up the absolute necessity of combination therapy.
You have to initiate a second-line steroid-sparing agent very early in the disease course.
To maintain remission once the steroids are withdrawn.
We will explore those specific steroid-sparing agents shortly.
Because the pharmacology is complex.
But before we open the drug arsenal, we have to audit one more critical system.
The heart is not the only organ that demands aggressive, immediate intervention.
We have to look at the central nervous system.
We need to discuss the devastating potential of neurosarcoidosis.
The central nervous system. The brain, the spinal cord, and the cranial nerves.
It is uniquely vulnerable to granulomatous inflammation because it is encased in rigid bone.
When a granuloma forms in the lung parenchyma, the lung tissue has elasticity.
It can expand to accommodate the mass.
When a granuloma forms in the meninges or within the spinal canal, there is no room for expansion.
The inflammation rapidly compresses vital neural structures.
The sources are unequivocal. Delays in diagnosing and treating neurosarcoidosis can lead to severe permanent neurologic disability.
Prompt recognition is paramount.
The clinical presentation is incredibly diverse, depending entirely on where the granulomas deposit.
A very common presentation is cranial neuropathy, specifically facial nerve palsy,
A patient might present with a sudden onset drooping of one side of their face.
mimicking Bell's palsy.
But it can also present with seizures if the granulomas irritate the cerebral cortex,
Profound cognitive decline,
hypothalamic dysfunction.
or severe peripheral neuropathies.
Diagnosing neurosarcoidosis requires advanced neuroimaging.
Clinicians rely heavily on brain and spine MRIs with gadolinium contrast,
They are looking for characteristic patterns,
such as nodular enhancement of the leptomeninges at the base of the brain.
or enhancement along the cranial nerves themselves.
They also frequently perform a lumbar puncture for cerebrospinal fluid or CSF analysis.
The CSF in neurosarcoidosis typically shows a lymphocytic pleocytosis
An elevated white blood cell count.
and elevated protein levels.
More importantly, the CSF analysis is crucial to rule out infectious causes of chronic meningitis,
Like neurosyphilis or cryptococcal meningitis.
which could perfectly mimic the clinical and radiographic presentation.
Once neurosarcoidosis is confirmed, the treatment pathway is exceptionally aggressive.
The therapeutic ladder is climbed much faster than in pulmonary sarcoidosis.
First-line therapy is high-dose corticosteroids to rapidly reduce the swelling and compression.
But if the symptoms persist, or if the patient cannot tolerate the steroid taper,
They immediately add methotrexate.
you do not linger on failing therapies when central nervous system tissue is actively being damaged.
Neural tissue has notoriously poor regenerative capacity.
Methotrexate is brought in as the primary steroid-sparing heavy hitter.
And if the disease remains refractory, despite the combination of high-dose steroids and methotrexate,
The protocol escalates to infliximab,
infliximab is a monoclonal antibody.
a highly potent biologic agent that specifically inhibits tumor necrosis factor alpha.
It has demonstrated remarkable efficacy in halting advanced refractory neurosarcoidosis.
The overarching clinical theme here is absolute urgency.
You escalate therapy aggressively and continuously until the neurologic inflammation is fully suppressed.
We have spent a significant amount of time detailing high-dose steroids, implantable defibrillators, and potent biologic infusions.
For the heart and the brain.
But the literature presents an incredibly counterintuitive fact about the broader sarcoidosis patient population.
According to the comprehensive reviews provided in our sources, Not all sarcoidosis requires treatment.
In fact, only 20 to 70% of patients will ever need systemic therapy.
This is often one of the most difficult concepts for patients, and sometimes even clinicians, to reconcile.
You diagnose a patient with a systemic disease characterized by inflammatory masses in their lungs.
And the prescribed management plan is watchful waiting.
It feels inherently passive.
It feels like an abdication of medical responsibility to just observe a known disease.
But it is rooted in the fundamental medical principle of non-maleficence.
First, do no harm.
The medications used to treat sarcoidosis carry profound, sometimes life-altering toxicities.
Corticosteroids, antimetabolites, biologics.
The decision to initiate systemic treatment is never based merely on the histologic presence of granulomas.
Or the radiographic appearance of lymph nodes.
It is based on a highly specific risk-benefit calculus involving 3 deciding factors.
First, is there a significant risk of severe organ dysfunction or irreversible damage?
Second, is there a risk of mortality?
And third, are there incapacitating symptoms
Like profound fatigue, severe dyspnea, or debilitating joint pain?
that are destroying the patient's quality of life?
If the answer to all 3 of those questions is no,
For instance, a patient has bilateral hilar lymphadenopathy and some scattered asymptomatic pulmonary micronodules.
but their PFTs are stable and they feel entirely normal.
We observe them closely.
A significant percentage of these patients, particularly those with early-stage disease or Löfgren syndrome,
Will experience spontaneous remission.
their immune system will eventually dial down the inflammatory response on its own.
And the granulomas will resolve without ever exposing the patient to the toxicity of immunosuppression.
But when the answer to any of those questions is yes,
Observation ceases, and you step onto the therapeutic ladder.
our sources delineate very clear, absolute indications where clinical intervention is mandatory.
Observation is never an option if the patient has cardiac involvement.
The risk of sudden death is too high.
We must treat neurosarcoidosis to prevent permanent neurologic deficits.
We must treat ocular disease that is failing to respond to local topical corticosteroid drops.
We must treat symptomatic hypercalcemia to prevent irreversible renal failure.
And we must treat progressive pulmonary disease, where serial PFTs demonstrate a worsening trajectory in lung volumes or DLCO.
So, when the threshold for treatment is crossed, how is the drug arsenal deployed?
This step-by-step approach always begins with the first-line defense.
Corticosteroids.
Corticosteroids, primarily oral prednisone, are the bedrock of sarcoidosis management.
They act rapidly by broadly suppressing the transcription of multiple inflammatory cytokines.
Effectively starving the granuloma of the signals it needs to form and maintain itself.
But the dosing strategy varies wildly depending on the severity of the organ involvement.
For a standard presentation, say a patient with symptomatic progressive pulmonary sarcoidosis.
Clinicians typically initiate prednisone at a moderate dose, usually between 20 to 40 milligrams daily.
That is generally sufficient to gain control of pulmonary inflammation.
But if the heart or the central nervous system is under attack,
That moderate dose is inadequate.
for cardiac and neurologic disease, the starting dose is pushed up to 1 milligram per kilogram of body weight per day.
Often capping at 60 to 80 milligrams.
And for truly catastrophic scenarios,
A patient presenting in cardiogenic shock from a complete heart block.
or experiencing severe spinal cord compression from a dural mass,
They bypass the gastrointestinal tract entirely.
they utilize massive intravenous pulses of methylprednisolone.
Administering up to 1,000 milligrams per day for 3 to 5 consecutive days.
It is the pharmacologic equivalent of dropping a water bomber on a forest fire.
But the clinical reality of corticosteroids is that they exact a terrible toll on the human body over time.
Chronic high-dose steroid therapy predictably causes severe weight gain,
Iatrogenic diabetes mellitus,
accelerated osteoporosis,
medically refractory hypertension,
cataracts.
and profound psychiatric disturbances, ranging from severe mood lability to frank psychosis.
You cannot leave a patient on high-dose prednisone indefinitely.
That harsh reality is why the European Respiratory Society and the ATS guidelines place immense emphasis on the early initiation of second-line steroid-sparing agents.
The clinical strategy is a handoff.
You use the rapid, blunt force of the corticosteroids to quickly gain control of the inflammation.
And halt the tissue damage.
Simultaneously, you start a second-line agent.
These drugs take weeks or even months to reach full therapeutic efficacy.
Once the second-line agent is fully active,
You begin a slow, meticulous taper of the corticosteroids,
with the ultimate goal of withdrawing the steroids entirely,
or maintaining the patient on a highly targeted minimal dose.
typically less than 10 milligrams a day.
while the second-line agent maintains the remission.
The preeminent drug in this second-line category, boasting the most robust supportive evidence,
And standing as the most commonly prescribed steroid-sparing agent globally.
is methotrexate.
Methotrexate is an antimetabolite,
It competitively inhibits an enzyme called dihydrofolate reductase.
which is essential for the synthesis of DNA and RNA.
By blocking this pathway, methotrexate specifically targets rapidly dividing cells.
Since the inflammatory cascade in sarcoidosis relies on the rapid proliferation and activation of T cells and macrophages.
Methotrexate effectively starves the immune response of the cellular fuel it needs to build granulomas.
It is highly effective, but it requires diligent monitoring.
Clinicians have to regularly check complete blood counts for bone marrow suppression.
And liver function tests for hepatotoxicity.
The guidelines also highlight azathioprine, mycophenolate mofetil, and leflunomide as viable alternatives.
The choice among these agents depends heavily on the patient's specific organ function
Tolerability.
and reproductive plans, as many of these drugs are fiercely teratogenic.
But what happens when the biology of the disease overrides both the corticosteroids and the antimetabolites?
When a patient remains highly symptomatic or their organ function continues to decline despite maximal therapy with prednisone and methotrexate,
We must move to the third-line therapies.
biologics.
These are reserved for truly refractory cases.
Owing to their significant cost, the requirement for intravenous infusions, and the risk of severe opportunistic infections.
The heavyweights in this class are the anti-TNF-alpha agents.
Infliximab and adalimumab.
Tumor necrosis factor alpha is a master inflammatory cytokine.
It plays an absolutely critical role in the architectural formation and structural maintenance of the granuloma.
The macrophages secrete TNF-alpha to recruit more cells and bind the structure together.
By administering infliximab, you introduce an antibody that binds to and neutralizes TNF-alpha in the bloodstream,
You are essentially pulling the molecular scaffolding out from under the granuloma.
causing it to structurally collapse and dissolve.
The sources also note rituximab
A monoclonal antibody that targets CD20 on B cells,
as a niche option for highly specific, difficult cases.
particularly when there is overlapping autoimmune pathology,
But infliximab remains the workhorse biologic.
showing incredible efficacy in reversing advanced pulmonary, neurologic, and cardiac sarcoidosis.
However, there is a massive caveat highlighted in the JAMA Cardiology and JCC state-of-the-art reviews.
There is a specific clinical scenario where infliximab transitions from a life-saving therapy to a potentially fatal hazard.
This is a nuance that underscores why managing complex sarcoidosis requires deep subspecialty expertise
Infliximab must be used with extreme caution
and is often contraindicated.
in patients who have severe cardiomyopathy with a significantly reduced ejection fraction.
The broader cardiology literature has demonstrated that in patients with severe heart failure,
High-dose anti-TNF therapies can actually worsen heart failure exacerbations and increase mortality.
so you have a patient whose heart is failing because it is full of sarcoid granulomas.
The very drug that is most effective at dissolving those granulomas, infliximab,
Could simultaneously accelerate the underlying heart failure and kill the patient.
it is an incredibly dangerous therapeutic paradox
Navigating it requires a highly delicate collaborative discussion.
between the pulmonologist managing the systemic disease
The rheumatologist managing the biologic.
and an advanced heart failure cardiologist.
They have to carefully weigh the risk of untreated granulomatous inflammation against the risk of drug-induced cardiac decompensation.
Speaking of that level of collaboration, it perfectly frames the logistics of caring for the sickest of these patients.
Let's examine the inpatient considerations.
Managing a hospitalized patient experiencing a severe sarcoidosis flare is never a solo act by a single attending physician.
It requires a highly coordinated multidisciplinary village.
It absolutely does.
When a patient is admitted with severe multi-organ sarcoidosis, the hospital management checklist is extensive and complex.
First and foremost, if there is even a shadow of a clinical doubt regarding cardiac involvement,
If they had a recent episode of syncope or a borderline baseline ECG,
that patient requires continuous telemetry monitoring,
you cannot afford to miss a transient heart block or a brief asymptomatic run of ventricular tachycardia,
they require vigilant monitoring of their respiratory status and oxygen requirements.
particularly if they are admitted for a severe pulmonary flare.
The nursing staff must regularly monitor their basic metabolic panel,
Specifically tracking those calcium levels.
because we know the granulomas are autonomously driving up 1025 OH vitamin D.
putting the patient at risk for a sudden hypercalcemic crisis and acute kidney injury.
Furthermore, there's the sheer hypervigilance required to manage the acute side effects of the massive corticosteroid doses we discussed earlier.
If a patient is receiving 1,000 milligrams of intravenous methylprednisolone,
The medical team must aggressively manage the resultant hyperglycemia.
often requiring insulin drips,
They must monitor the blood pressure, which will spike due to fluid retention.
and they must carefully observe the patient's mental status.
As high-dose steroids can induce acute delirium or psychosis,
No single physician can manage all of these facets optimally.
the consult roster for an inpatient with severe sarcoidosis is extensive.
Pulmonology is typically the primary admitting service.
Managing the diagnostic procedures like the EBUS-TBNA and the overall immunosuppressive strategy.
Cardiology is essential for interpreting the advanced imaging.
Managing the telemetry and evaluating the need for pacemakers or ICDs.
Ophthalmology must be consulted to perform the required slit lamp examination to rule out acute uveitis.
And depending on the specific manifestations.
Neurology is brought in to manage central nervous system involvement.
And rheumatology is frequently consulted to expertly guide the initiation and titration of complex second-line and biologic agents.
Which brings us to the ultimate question that every patient and clinician eventually faces.
After all the rigorous testing, the systemic screening, the complex pharmacologic management, and the multidisciplinary coordination.
What actually happens to these patients? What is the prognosis?
The data from the sources show that the prognosis spectrum is wildly divided.
It really is a tale of two entirely different disease trajectories.
The clinical heterogeneity of sarcoidosis is most apparent when you look at long-term outcomes.
On the highly favorable end of the spectrum,
The good prognosis group.
we have patients presenting with Löfgren syndrome,
Despite how intensely symptomatic and miserable those patients feel acutely.
with the fever, the profoundly swollen joints, and the painful erythema nodosum nodules.
That specific clinical presentation carries a highly favorable long-term prognosis.
The vast majority of patients with Löfgren syndrome will experience complete, spontaneous remission within 1 to 2 years.
And will never require long-term immunosuppression.
The same favorable outlook applies to patients with isolated stage 1 pulmonary disease.
This means their chest imaging shows bilateral hilar lymphadenopathy.
But the actual lung parenchyma remains completely clear of granulomas.
The rates of spontaneous remission for stage 1 disease are exceptionally high.
But then you look at the other side of the spectrum.
The bad prognosis markers, where the disease behaves relentlessly.
The outcomes are markedly worse, and the risk of mortality climbs significantly if the patient has any degree of cardiac involvement.
Simply due to the risk of sudden arrhythmic death.
Neurosarcoidosis also carries a poor prognosis due to the potential for irreversible neurologic deficits.
And pulmonary fibrosis is a definitive marker of poor outcomes.
Once the granulomas in the lungs burn out and leave behind permanent, rigid collagen scar tissue,
The lung architecture is destroyed.
the patient develops restrictive lung disease
Pulmonary hypertension.
and eventually right-sided heart failure.
The sources also highlight chronicity as a major prognostic red flag.
If a patient has active, poorly controlled disease requiring ongoing immunosuppression for over 5 years,
It points to a relentless refractory phenotype.
these patients are likely facing a lifelong battle with both the disease and the cumulative toxicities of the treatments.
It is a profound clinical challenge, managing a disease that can either vanish completely on its own or quietly destroy multiple organ systems despite maximal medical therapy.
We have covered an incredible amount of clinical ground today for you.
To briefly summarize, we started with the diagnostic triad.
The clinical presentation, the non-caseating granulomas, and the critical exclusion of all other causes.
We explored how EBUS-TBNA provides a safer route to tissue conformation.
And we highlighted the specific pathognomonic presentations like Löfgren syndrome and lupus pernio that allow us to bypass biopsy entirely.
From there, we examined the mandatory systemic screening.
Checking the pulmonary function with DLCO, examining the eyes with the slit lamp.
And rigorously checking labs like serum creatinine and the dual vitamin D levels,
We analyzed the high stakes of cardiac and neurosarcoidosis.
where symptoms like syncope demand immediate advanced imaging like cardiac MRIs or PT scans.
And finally, we navigated the therapeutic paradox
That up to 70% of patients may not need treatment.
before detailing the aggressive use of corticosteroids.
The reliance on methotrexate for steroid-sparing maintenance.
and the targeted, cautious use of biologics like infliximab in advanced disease.
It is a massive amount of information.
But there is a final concept I think is crucial to consider, drawn from the subtle implications in the research literature.
We have spent this entire deep dive discussing how to chase down and suppress these granulomas with increasingly heavy-hitting drugs.
We utilize high-dose steroids, antimetabolites, and powerful monoclonal antibodies to crush the immune system's response.
But if sarcoidosis is, at its biological core, an overzealous immune response to an unknown invisible trigger,
Perhaps an elusive environmental exposure, an unidentified occupational antigen, or a cleared infection that left a lingering immune scar.
are our current treatments simply putting out the fires while the arsonist remains completely free?
What if the true future of sarcoidosis management isn't about inventing a stronger steroid or a more targeted biologic to suppress the macrophages?
What if the future relies on finally identifying that invisible trigger, allowing us to stop the fire from ever starting in the first place?
That is exactly the kind of perspective that keeps the medical field pushing forward.
If we can definitively find the arsonist, we won't need to rely on the fire hose.
Thank you all for joining us on this exploration of sarcoidosis. Keep questioning the consensus, keep exploring the intricate mysteries of the human body, and we will see you on the next deep dive.